Healthcare in America. Follow the money post. 7. Chronic disease, the real cost driver. We've traced who pays, where the money goes, how a dollar moves, and insurance mechanics. Now we turn to the factor that drives most healthcare spending: chronic disease. 1. The scale of the problem. Chronic diseases, including diabetes, heart disease, obesity, and autoimmune conditions, account for roughly 70–80% of healthcare costs in the United States. Millions of Americans live with multiple chronic conditions. Treatment is ongoing: doctor visits, tests, medications, hospitalizations. Costs compound over time, often creating financial stress for patients and strain on insurers and providers alike. The system is designed to manage acute events well, but chronic conditions create persistent demand, exposing structural inefficiencies. 2. Incentives and misalignment. Fee-for-service care. Providers are reimbursed for procedures, tests, and visits rather than long-term outcomes. Preventive care under-incentivized, counseling, lifestyle support, and early intervention are often undervalued financially. Patient behavior versus system support, access, food systems, socioeconomic factors, and education all influence health outcomes, but the system primarily reacts to illness rather than preventing it. The result: the machine is built to treat disease efficiently, not necessarily to prevent it. 3. Chronic disease and costs. Hospitalizations, recurring admissions for complications, medication, often lifelong, especially for diabetes, hypertension, and heart disease. Long-term care. As patients age, care needs increase. Lost productivity, societal costs from absenteeism and disability. Even when the system works as intended, costs escalate because chronic disease requires ongoing resources. 4. Why this matters. Understanding. Chronic disease as a cost driver changes the conversation. It is not about villainizing providers, insurers, or patients. It is about structural incentives and the mismatch between treatment and prevention. It shows that high spending is not random. It reflects the persistent demand created by population health trends and system design. Do you begin to see a pattern? The machine isn't broken because of greed. It's stressed because of chronic demand and misaligned incentives. Next, we will examine rural healthcare and consolidation, showing how the same structural pressures hit small communities even harder. Hospitals close, services disappear, and the machine's complexity has real, tangible consequences for everyday Americans.